In 2008, the World Health Organization Commission on the Social Determinants of Health suggested that maternal and child health were key areas for interventions that could be implemented to tackle health inequalities. So what we decided to do for this particular presentation was to select indicators in child and maternal health that would demonstrate some of these differences and highlight some of these solutions. And our first slide here shows that the differences between the quintiles. Dr. Nyanjom introduced the concept of income or wealth or socioeconomic quintiles, with Q1 being the poorest and Q5 being the richest. And Q1 will be in dark blue for this presentation, Q5 in a lighter shade of blue. From the slides, it's clear that under 5 mortality is higher in those in the poorest quintile, and stunting, which has long-term consequences for children, for adults, in terms of brain development, in terms of overall development, in terms of growth, is almost twofold in the poorest quintile. So this slide demonstrates differences between utilization of health services by quintile. So we've got ANC utilization, attendance by a skilled birth attendant, that's a doctor, midwife, or a nurse, and insurance coverage by quintile. And I mean, look at the differences. I mean, 3% insurance coverage in the poorest quintile in Kenya versus 16% in the wealthiest. The national average is 17. We know there's a problem with quality health services in Kenya, and so what happened is that there was a sharp reduction in effective coverage. That's coverage with services of the right kind of quality to give you the right kind of outcome. But the problem is greatest in those who are in the poorest quintile. I mean, look at ANC services. ANC services are critical, to ensuring a healthy mother, a healthy child, a healthy adult. And you've got only 15% of those in the poorest quintile accessing services that are of sufficient quality to get them there. So how to fix this? Universal coverage has been touted as the fix-it for attaining equity in health. Its aims are simple. Access for all, utilization according to need, and protection from financial catastrophe. What does this mean for the health system? It means whole health system changes. UHC is not about changing the health financing system, it's about changing the entire health system. So changes in service delivery, a focus on community care and primary care, changes in personnel mix, changes in health financing in terms of revenue generation. So you do need greater public spending that is progressive. You need systems that allow effective cross-subsidization from rich to poor, from healthy to sick, from young age to old age, which means some system of pooling, often some form of social insurance, but not necessarily so. The other way is to push your members to join the NHIF. And the NHIF's payment scheme is supra-county, right? So it doesn't care what's happening at the county level. So if these people came in and you insisted that each time you come in you need to be capitated to this facility, then your payments would be free of all the political stuff going on and all that stuff, it would be impossible to sort out.